And a very good evening to you. I am Lisa Lord, and on this one-on-one, we will focus on emergency medicine with particular emphasis on the Barbados Emergency Ambulance Service. And my first special guest is the head of the Barbados Emergency Ambulance Service, Dr. David Beyer. Dr. Beyer, thank you so much for joining us on your program.
You are most welcome. I'm happy to be here.
I'm happy you are as well. You're a hard man to track down. Now, I want to start first by saying that you're not dealing at all with the accident and emergency department at the Queen Elizabeth Hospital. We do tend to focus on the hospital, however, and what happens when patients arrive, but a lot goes into transporting persons to the QEH. So let's look at what pre-hospital emergency care is.
Sure. So this is everything, as the name suggests, pre-hospital. So we're looking at the medical care and transport before getting to actual dedicated care at the hospital. And it involves not only the ambulances and ambulance personnel, but it involves basically all levels of caregiver, even those who are not in the medical field. And it also involves bystander education, bystander input, etc.
And how is pre-hospital care done in Barbados?
Sure. So the major agency is the Barbados Emergency Ambulance Service, which I'm the medical consultant. And so we also have other private ambulance services, maybe there are about 3 or 4 who also are available for medical care and transport. And so we work harmoniously together, again, with some of our other emergency responders in terms of fire and police, basically in terms of crisis response.
I want to take an in-depth look at the Emergency Ambulance Service, which is the public provision of ambulance services. How many employees do you have?
Right, so we have 76 employees, of which 60 are road personnel, which is a mix of paramedics, which are advanced trained EMTs, and emergency medical technicians. That's what the word EMT means. So they basically function 2 on each vehicle in terms of servicing the public's needs.
And of course, they work 24 hours a day,
7 days a week. And they are already backed up also by a able group of dispatchers, who are the persons who take the 511 calls and basically assign the ambulance to the task, as well as there's intermediary management team, supervisors, other managers who make sure that the whole system works.
Are you understaffed?
Yes. We've asked for more staff in order to provide better for the needs of the public.
How much more staff do you need?
Well, I mean,
ideally,
I will say that, in our heads, that basically amongst a number that can put more ambulances on the road. So we've had the discussions with our payroll ministry in terms of what we can aim for.
Is your staff then overworked?
I think that once you're in the field, you always will be overworked as an emergency provider. And that's not necessarily due to the volume, that's also due to the nature of the job.
Let's look at the stations that you operate from.
Yeah, so we have 2 stations that we operate from. We operate from Wildy, which is our headquarters, and we also have a smaller station at Arch Hall, which was developed maybe just short of 20 years ago, to improve the response time to northern and western Barbados. In addition to that, which really would be decentralization, we also do some level of deployment in that we have ambulances on the road, and we have the GPS on them so that we can identify where they are and respond better to where crises are with them being on the road. They don't need to be in a station to respond.
Come back to the GPS and the tracking system a little later. Let's look at your relationship with the Barbados Fire Service.
Sure. So again, as one of our sister agencies in terms of emergency response, we cohabit Arch Hall, as you know, and soon we will cohabit another station when they build their headquarters in the Pine in maybe just short of a year or so, according to what I'm being told. Certainly we work harmoniously with them especially in terms of mass mass patient events where there are multiple patients, also in terms of where there are complex patient situations where persons have to be extricated, which means basically, cut out of a vehicle or remove out of the vehicle for safety reasons.
And I'm going to stick a pin on the mass casualty events as well. How many ambulances do you have in your fleet?
Sure. So we own 9 ambulances now, and basically we're able to put, I would say, somewhere in the region to 6 to 7 on the road at any one time.
So those other two are out for mechanical reasons.
No, I think basically the aim is always being to have a fleet which is more than what you actually need. And I think we're working towards that. I think that's the tenet in terms of most emergency services to have more resources that they need. And the reason is that these vehicles are on the road 24/7. And obviously the wear and tear is great. So you gotta basically be able to take them out for preventative maintenance and rotate vehicles, etc. So I think that is the mantra in terms of how most emergency services operate. I'm pretty sure that our sister agencies in terms of police and fire, they do have more vehicles than they actually have functioning at any one time. And that just, and internationally, that's how it goes, basically in terms of having more to be able to allow for that level of intensive preventive maintenance.
But 9, is that enough to service?
No, so we're aiming for 12.
Aiming for 12.
And certainly we're on our way there. Certainly we should have one hopefully within the next month or so. And in 2024, we should be able to, again, maybe get 1 or 2 more vehicles. But again, this is dynamic because that depends on the fact that the ones who wish are working remain working. And certainly, things happen. You may have motor vehicle accidents, you may have mechanical issues, etc. So we are hoping that we can attain a fleet of 12, which would allow for us then to properly execute whatever level of preventive maintenance is required.
How many ambulances have you lost in the last few years? 2 accidents.
We've been fortunate, I think, over the last few years, maybe just off the top of my head, I'd say maybe about 2 or so. And luckily, and most importantly, there were no major injuries either to staff, public, patients, etc. Obviously, you're driving a vehicle with lights and sirens, and different things are possible. And, that's just, I will say, internationally, it is a risk.
And your drivers have to be very well trained because they are driving at very high speeds as well.
Well, I know we always cite speed, but to be honest, the lights and sirens are to be used as alerting devices for persons to move out of the road to allow for better progress. So we do have some challenges with that in terms of sometimes persons may not appropriately make the road free for progress in terms of the ambulance. And then we do have some challenges with persons sometimes tailgating. They make the wait until the ambulance goes by, and then they go into just behind the ambulance, sitting there just in that space that's created in terms of getting forward as well. Again, which is not something that we condone because it's a dangerous thing both to them and to the persons in the ambulance, etc. So, I mean, in summary, I'd say the lights and sirens act under the law and internationally again to basically allow for better passage, smoother passage of the ambulance around. So yes, you want some level of speed, but speed sometimes basically increases the risk of accidents and injury. So the major thing is to use the lights and sirens in terms of to move traffic along.
And I'm listening to you and I'm so confused as to why some motorists are still not cooperating to allow the ambulances smooth passage through the traffic.
Yeah. Well, that's a product of a number of different things. Sometimes there isn't actually any space to actually move out of the way and stuff. So, I mean, certainly one road that comes to mind is the Collimer Road and stuff.
Yeah, it is
it's tight up and down and stuff. So, I mean, with the best intentions, sometimes it's a little bit of a challenge. Sometimes persons may be distracted in terms of things they may be doing in the vehicle, telephone, music, etc. Sometimes basically the cars are so advanced nowadays that certainly, they're almost soundproof, so you can enjoy your music, so you don't hear anything on the outside. And I suppose part of it also on our end, and something that we're trying to work on, is to improve our visibility and sound so that basically the ambulances are more visible in terms of more LED lights and stuff so that you don't miss it, and also to improve the positioning of the actual horn and stuff to try to make it as apparent as possible.
That's another concern for some motorists as well, that they don't hear it. It's not loud enough.
Yeah, so I've heard that, and it's something that we're actively working on.
Okay. Now, in terms of the number of calls the service receives annually, I think the last number I saw floating around was about 15,000.
Yeah, so we do roughly about 15,000 calls in a year, and that has been relatively constant over the last few years or so. If I were to break that down,
please.
Yeah. So we do about 80% of non-trauma, which would be medical calls, which would be things like stroke, heart-related issues, persons not feeling well. So the other 20% will be trauma. And in terms of the mix in terms of adult versus pediatric, you roughly do about 90% adult versus 10% pediatric or children. So that has been relatively constant over the last, I'd say, decade in terms of that percentage mix and the total volume of calls.
Are you still having the challenge of prank calls?
Yeah, we do. I'd say that we're pretty vigilant with that there now, in terms of that there, especially in the vacation periods in summer and stuff. Sometimes we have people, well, I'd say young people do it, but we're able to identify them sometimes and basically able to put systems in place to have that there, to limit that, I would say.
And then nuisance calls, where persons would call for an ambulance. You get there, you assess them, and nothing is wrong.
Yeah, so I mean, there are many sides to that there as well. So sometimes a person who basically isn't the person who we're there to assess is not the person who's called for the ambulance. It may be somebody who basically be of the impression that they're doing a good deed. And so, to basically adjudicate blame is not always the case. I know we're happy to, go evaluate and, if basically nothing is wrong or nothing major is wrong, I mean, that works so well for everybody in terms of the patient per se. Yes, we may then be delayed in terms of going to other calls and stuff, but I'd say that, persons sometimes have a low threshold in terms of calling the ambulance, calling for help. And I think that, that there is something that we're working on through public education. I think that sometimes people panic. And I think that if we can have a culture whereby that you can have more people knowing first aid, knowing CPR, knowing those types of things, it will be, probably be more responsive there. Some of the conditions are time sensitive in that, yes, with the best intentions, yes, you may need an ambulance, but certainly the steps that are done initially are key in terms of the final outcome.
What happens when your crew, they go out? Some person needs to be transported to the hospital, but that person does not want to go.
Yeah. So we don't have the powers of arrest. We can use suggestion, reason, and to some extent, some level of coercion, but certainly we're not in a position generally to grab someone and throw them in the back of the vehicle to take them.
You said Jen.
Yeah, so there are some situations whereby persons may not be of, I'll say just loosely, of sound mind. Mm-hmm. And let's just say, for instance, that there was someone, a diabetic, who had low blood sugar.
Yes.
Obviously, in terms of them having the capability to make a rational decision based on their medical condition is not there. So in those scenarios, we always thinking in terms of for the greater good. So we try to have a robust communication system, either with myself or basically with the hospital, in terms of identifying those cases. Sometimes it may take working with the other persons who are around, whether they be family members, friends, or the police, in terms of making sure that those persons get the relevant care necessary.
There is the belief over the years that by arriving at the A&E by ambulance, you're seen quicker.
Yeah. So the triage system at the accident emergency is done, the same way depending on how you enter. Meaning, if you go to the front basically by a private vehicle, at some point basically the triage nurse sees you, does some level of assessment based on your condition in terms of the clinical information they obtain through a history examination, and then they make a determination based on your priority. It's the same thing when you come by ambulance. So therefore, somebody greets you, makes an assessment in terms of what's going on, and depending on what your condition is, you may find yourself remaining in, yes, but you may also find yourself being moved to the waiting area as well.
But you understand why people might think that because you have somebody trained saying, well, we've brought in this patient, as opposed to a family member who's saying, you need to see my relative.
Sure. So again, we basically transport everybody that calls for ambulance as best we can. So certainly, yes, a medical team transports you in, but they would have made their assessment as well, and they give those findings over to the nurse or doctor there, and then basically some level of decision making is made at that point in terms of where the disposition of the patient is.
Speaking about decision making, we're dealing with life or death scenarios sometimes. And the ambulances are equipped with GPS tracking, as you mentioned earlier. So you have had cases where a crew may be on their way to what you would consider a non-emergent case, but then you have a serious case, and that ambulance then is diverted based on priority.
Yeah, so that was the reason that it was intended in terms of to allow for rerouting. So just to put that in practical terms, let's just say that an ambulance was headed to say St. Lucie, and it was a let's say it was a low priority case and stuff, and then we would have received through a dispatch a call for someone who's had a stroke or a heart attack or even a traumatic incident like a shooting, let's just say somewhere on the path, somewhere on the West Coast or so. Generally able to identify the closest resource and be able through radio or cellular communication to reroute that ambulance to that more urgent or emergent case.
How long ago was GPS tracking installed?
Yeah, so we've been doing this now, I can say probably for the last approximately 10 years or so.
After a decade, how well is it working?
It works quite well in terms of being able to make some key saves in terms of it. And so, I mean, the only thing is that certainly it works when the ambulance is free of patients. When there's a patient engaged in the ambulance and stuff, obviously you can't put them up. So basically it works when an ambulance is on its way to a case, a low priority case, as you said. But certainly once we have that low priority case in, basically, you got to wait until we find a free resource to do the response.
You keep mentioning low priority, so let's look at the two categories.
Sure.
What is considered low priority cases? What are considered high priority cases?
Yeah, so basically in our heads, basically high priority cases are things which basically are life or limb threatening immediately. Things we usually say the ABCs: airway, breathing, circulation, things which impact in terms of those. And that may involve things with internal or external bleeding, things where persons aren't breathing appropriately, things where persons' hearts and stuff aren't functioning appropriately, blood pressure issues, or so. So those types of things are things basically which are, as I said, time sensitive and require some level of immediacy in terms of care. There are things which basically are serious. I mean, persons may be in pain or some level of discomfort or so, but in our estimation, it may not. They're not emergent. They wouldn't be considered an emergency. Yes, they may be uncomfortable. We understand that. We understand care is required, but it basically, if you were to put them against the other things, it's not something that you'll probably die from immediately. So, it's all about this whole thing about triage is in terms of trying to, I suppose, sort patients so that the more emergent or urgent cases are attended to first. So I take some level in terms of getting information, doing some level of examination in terms of trying to put it all together in terms of then deciding how the resources are allocated.
Now, you are a veteran in emergency medicine. You're usually the doctor on the scene whenever we have a mass casualty situation, unfortunately. But let's look at how a mass casualty situation is actually defined to begin with.
Sure. So it's sort of defined in two ways. Basically, any incident whereby the number of patients would overwhelm the resources at the accident emergency department. And so we've identified generally that number to be 12 as the limiting number. However, there are times when that number there may be lower. Okay, it all depends in terms of what's happening as an emergency. So for instance, let's just say that there were, inundated with patients and it was quite full. Sometimes we may make that call basically for a lower number of patients and stuff. So what it involves though is that to actually get out there and actually see what could be done in terms of the scene, in terms of treatment, and then in terms of prioritizations of patient transport to see whether there are patients that could be seen at the scene and discharged, if there are patients that could be seen and rerouted to another lower acuity care setting, like a polyclinic or so. Sometimes patients opt basically sometimes to seek private care and stuff, So, but the main thing is to do some level of assessment and basically then to determine what number of patients are there and to get the right resources ready for the right patient. What I will also say is that so the mass casualty approach is not something only done in terms of the field, in terms of how we sort of sort the patients, triage the patients, as we say. There are things which are trained within the hospital and in the health centers in general, in terms of communication to the polyclinics, etc., that there may be more patients coming your way, communications to the accident emergency in terms of what sort of patients they are. There's usually some level of incident command whereby persons, it has come down to a point where we've had situations where the surgical procedures that are elective, they're ongoing, maybe halted until basically, just everybody's basically is in the mindset that there may be serious patients coming in and that we may need to do things to make sure that they are ready for them when they actually arrive.
Around the middle of October, you and your team responded to a mass casualty situation involving 2 transport board buses. This was in St. James. 61 people were treated at the scene, 19 of whom were sent to the QEH for further treatment. And based on everything you just described, that's a lot of people, and it places a lot of pressure on the hospital system as well.
Yeah, it did, certainly, especially with the fact that a lot of those patients were, I will say, minors. And the challenge always with minors is that, people may be scared.
Yes.
And so as much as the physical input is there in terms of making sure that they're well, there always needs to be that psychological overlay to make sure that they're comfortable, make sure that you help them find their parents and stuff to let them know what's happening. Of course, they have anxious parents around who wants to know what's happening, and that's reasonable. So it's a multifaceted thing that you need to manage. And it's just not a medical operation, but you need to make sure that all the other ends are sorted. And so that was a challenge, not only from the volume of patients, but also to make sure that we would have interfaced with the correct entities, not only the usual police, fire, Barbados Defense Force, etc., but we also interface with the Ministry of Education, the teachers who were from the schools that the patients were from, just to basically allow for that level of communication to take place, to see how best what we could do at all ends, both for the actual patients who were on the bus, but also for the parents and the other guardians and even the teachers and stuff who obviously be worried in terms of what's what.
Now, in terms of transporting those patients, you said you have 9 ambulances, 7 on the road. You transported 19 to QEH. Some of them also went off to the polyclinics. How do you transport all of those patients?
Yeah, so we have a system whereby, depending on what the scenario is, we can use ambulances to transport more than one patient. So, for instance, in that situation, there were patients who could sit.
Yes.
And there were patients who could lay. So you're just in terms of using your resources, in terms of moving those patients in an orderly fashion to medical care. And also we have this overriding relationship with a transport board. And so what we normally do is to basically contact them. So we would have had 2 or 3 buses available there for transport. And we usually use those for the lower acuity patients. So we would have moved those to a couple of the polyclinics and stuff as well. So we use all, it's not only ambulances involved, sometimes we've had to use trucks before, we've had to use police vehicles. Whatever is required to be able in a timely manner to get people to care, we basically work as a team to get it done.
And you do have a relationship with the private emergency medical facilities as well?
We do. Both in terms of the ambulance services So in large events, and it takes my mind back to the famous Josie River, we will basically work with them in terms of moving patients, both in terms of public and private entities. And then we also do have some relationships with some of the private urgent care centers and stuff as well, and even private hospitals. So there are operable MOUs, memorandum of understanding, basically, which will allow for care to be divvied up, shared between these resources.
And there's also the misunderstanding that if you're at a private emergency medical facility, that you can't call a public ambulance.
So you can. The only thing is that we take all of our patients to the public hospital. So sometimes
right. So I'm talking about you're at the private, but you need to be transferred to QEH.
Yeah. So we actually basically do that there routinely or so. Again, that forms a number of our calls in terms of from not only private urgent care centers, but also from private doctors' offices in terms of moving patients to a hospital and so. So yes, that is part of the offerings of the emergency ambulance service.
No, there's a lot that can be done before the paramedics get to a scene or to a home or to a doctor's office. You said that there is the need for more persons to be trained in basic first aid and CPR.
Yeah. So again, it is something that we basically try our best in terms of doing outreach. So we try whenever there are school career showcases to get out there and basically not only show the students in terms of possibility, in terms of career, but also we always do things like a mini CPR type course or some first aid type things to give them at least the rudiments in terms of medical care. It is something that we like extended, whereby that most organizations, whether they be businesses, etc., at least have someone there who knows first aid CPR. Certainly in terms of sporting organizations, sporting events is key. Because as you know, basically that is a hotbed of potential injury or illness, etc. So in terms of that, so we actually trying to work behind the scenes to have public access defibrillation. So what this means is that basically, I don't know, most people travel and they see sometimes these defibrillators on the wall. Yeah. And certainly the training is quite simple in terms of using them, but they're actually difference makers in terms of if someone goes into a regular heartbeat, a heart attack, cardiac arrest as we call it, in terms of making the difference between your heart beating correctly again and basically restoring your circulation, or unfortunately death. So we've had some noted people. I think most recently, LeBron James, and it can happen to anyone. LeBron James' son recently, he had a cardiac arrest on playing basketball, and then there was a NFL player, I believe, recently again. And the quick action of those around basically was basically instrumental in saving their lives. So I think it's something that we like to see here, where we can have most of the organizations. I think some of the gyms have done it. Some of the mass crowd places like the malls have done it. Certainly some of the hotels have done it, but we'd like to see that they're basically a bit more in the community where we have these devices, as well as have persons trained in terms of first aid, CPR. I mean, I think the days in terms of using smelling salts and putting things in people's mouths and stuff, cloves and stuff, that those things are somewhat old wives' tales and may not add anything in terms of the person's outcome. So we need to get basically in terms of to have people out there who can do something and report accurately until the credible medical help comes. We've been working a lot, trying to work with the lifeguards and stuff, because again, as a tourist entity, lots of people use the oceans, the beaches, etc. And, it is obviously a place where things can happen. So we've been working with the lifeguards, and we hope to work with some other organizations as we go into the new year in terms of sort of, I'm going to say, cultivating an awareness of safety through basically persons doing first aid, CPR, etc. And basically having a positive impact in terms of resuscitation.
If you could break down for me medically just how critical CPR is in terms of helping some person to breathe, that they don't end up with brain damage, etc.
Sure. So, I mean, when the heart basically is the motor for the body in terms of getting blood and stuff around, nutrients around. So when it stops beating, either it's an electrical organ, it has electrical impulses and stuff. So when that there goes awry, either there's an irregular electrical pattern, or there may be no electrical impulses going at all. It is important to keep the heart beating to get basically oxygen and other nutrients around. So we know that basically that if there is no circulation to the brain in somewhat as short as 5 minutes or so, there's probably going to be some level of brain damage. And we know that certainly if there's no appropriate circulation around for as long as probably 8 to 10 minutes, that the mortality rate is going to be very, very, very high. In fact, I would say close to 100%. So it's key in those first few seconds, minutes to identify that someone is having a cardiac arrest, and the appropriate steps, which involves calling for help, starting cardiac compressions, which is basically chest compressions and stuff. We know people may be a little bit not so keen in terms of putting their mouth on people's mouths nowadays in terms of infection transfer. But certainly the chest compressions has been shown to be quite effective in terms of maintaining some level of circulation throughout the body, as well as using this, what we call it AED, automatic external defibrillator, to apply the pads and see if there's a rhythm there that can be shot back into its normal rhythm to allow the heart to continue beating and continue that good flow of blood, oxygen, nutrients throughout the body. So it's key. And this is one of these time-sensitive things. This is something that basically that needs to be done within the first few minutes or so. If not, the mortality rate is quite high.
And I'm glad you mentioned things being time-sensitive. Do you have a response time that you like your crew to get to an emergency?
Sure. So, I mean, with the best of intentions, I'll tell you international standards. So certainly you would like to get to an out-and-out emergency within 8 minutes or so. However, let me just say, even in the strongest of jurisdictions where they have lots of resources, there's always a challenge in that, in terms of the distance, in terms of even to get to a building, identifying where the patient is, etc. So that's where it's key to not only improve resources in terms of ambulance and personnel training, etc., but also to make sure that the persons who are there call for help early, but also basically do something until help arrives. Because it's not always about the ambulance and the ambulance getting there and stuff in all situations. Sometimes it's basically in terms of persons helping prior to the ambulance coming. So I say that to say that it's something that we are trying to encourage at, say, sporting events, to have someone there who is medically trained, in terms of places where there's mass congregation, to have someone there who's medically trained, because with the best of intentions, 8 minutes is a very, very short time.
Yes.
And if you were to think about it in terms of moving, if we're here in Wildy, so let's just say that the ambulance had 2 personnel in there ready to go, and they were an emergency, let's say in 6 roads and stuff. To get there 8 minutes basically is doable, but it may be a little bit of a challenge. So it's important in terms of that period of time that basically people do something until the ambulance comes. Now, mind you, we're trying to work in terms of to see how best we can decentralize even more. And obviously, St. Philip, St. John, St. George, we know that that is an area that we're looking at and stuff. But even with that, certainly, a lot of these things require immediate action by those around.
And you do know why I asked, because the public has been very critical of the service in terms of its response time.
Yeah. So again, certainly there were, in terms of the number of calls which come in at any particular point in time, is variable. Sometimes, so we said there are 15,000 calls in a year. So maybe that's 50, 60 calls in a day and stuff. Sometimes those calls basically don't always come, let's say 24 hours in the day, 1 to 2 every hour. Sometimes they may have 5 or 6 calls at one time. And basically, if that there may occur, sometimes you may have scenarios whereby someone basically may be at the lower end of the queue, especially if basically the ambulances are already doing other function and stuff. So it's a work in progress. And, just from, I sort of try to to improve our system, have conversations with persons who are in other territories, first world, etc., in terms of the challenges they face. And they also face them in terms of, having a delay and stuff. So it's something that we can try to improve in terms of number of personnel, number of ambulances, etc. But there will never be a perfect system. But we'll try our best to try to provide for, whatever adverse situation is there.
Dr. Boya, over the years, I think you've been with the service from about 2005, 2006. What concerns you, bothers you, either when you go out, let's say to a mass casualty event, or when your crew reports back?
Yeah. So I think that for the most part, we get cooperation from the general public. I think everybody is happy to have help arrive and basically in terms of to render care to the individual. We've had situations though where not everybody at the scene is pro-patient, and this especially occurs at some of the scenes of traumatic interpersonal violence, some of the shootings, etc. And you can't assume. And sometimes we've now, I'd say in the last few years, had to work more closely with the police in terms of make sure there's scene safety. So we've had scenarios whereby we have gone to help patients, but everybody there doesn't want the patient helped.
Really?
We've had to basically what we call scoop and run, in terms of to basically scoop the patient in and basically go to another point in terms of to render care. So that's always a concern. And that's something that we're working with our law enforcement colleagues in terms of trying to make sure that those persons, both the responders as well as the patients and stuff, are safe. The other thing that basically is creeping its way into our realization is that the persons sometimes use their phones, and basically the intent seems to be of generating interesting videos to propel through social media. And there are times where it looks to us as if those are key minutes where things positively could be done in terms of whether it's calling for help or doing something in terms of stopping bleeding or something of that sort. And it's something that I suppose, I'm not saying is basically part of our culture, but you find it more frequently now. And it's something that I think that we as a people, as human beings and stuff, should look at and to recognize that, if you have the opportunity to do something positive for a person, you should. Filming it, for likes or I don't know, or whatever, probably does no benefit to anyone.
I am stuck on the point about the scooping and running to render medical assistance. In a case where you go, let's say, to a stabbing or a shooting incident, is it a case then that you have to go when the police and get there at the same time as the police?
So we've had situations where we've had basically with these incidents actually standard operating procedure now to inform the police when the calls come in. And basically there are times where we've had to go to rendezvous points and enter with the police or wait until the police basically say that the scenes are safe, because there are situations where there may be active shooting.
Right.
And there may be a situation where perpetrators and stuff are still on scene, etc. So you need to make sure that when you're rendering care and stuff in terms of that, you're trying to do it on the one of the things that we believe is that scene safety is key. And basically to make the scene safe basically involves law enforcement. And it's something that we now are trying to, it's more clear that it needs to be done. And it's something that we are adopting in terms of basically working closer with our law enforcement colleagues in terms of making sure that they're seeing safety.
I am stunned. I was not expecting you to say that at all. But in terms of your vision and your future plans for the Barbados Emergency Ambulance Service?
Yeah. So I think obviously, in short, as you alluded to earlier, you need more staff, more ambulances, etc. Those are short-term things. But the system, in terms of basically how you approach patients and stuff, is something that we need to look at. So we may need to involve have a multi-agency response where we can empower fire, police, and lifeguards, etc., to be better trained in terms of basic medical care and stabilization, because sometimes they do get there first and sometimes their hands and things are key. And this occurs in some other jurisdictions and stuff where the police and fire and the other first responder agencies also render some level of first responder medical care. And we need to work in terms of the public, and both in terms of general public, but also in terms of organizations, in terms of making sure that they have not only the training, but also the necessary equipment, whether it be a first aid bag or whether it be a defibrillator or so, to be able to render care where care is needed. So I think that is more even that is probably as important in terms of getting ambulances and stuff, in terms of getting basically involvement prior to ambulance reaching the scene, etc.
Dr. Boyd, it has been a pleasure. Thank you so much for sitting and talking with us this evening.
Absolutely.
That was Dr. David Beyer, the head of the Barbados Emergency Ambulance Service. And then we return, we will speak to a senior paramedic who has pretty much seen it all. Stay with us.
As Barbadians prepare for the Atlantic hurricane season, here is some information about shelters. Shelters are listed in 2 categories. A Category 1 shelter may be used during a hurricane or other hazard event, while Category 2 shelters may be used if they are still in a reasonable condition after a hazard event or disaster. Persons are advised to make their way to shelters well in advance of a storm's arrival.
Welcome back as we continue our look at emergency medicine with a particular emphasis on the Barbados Emergency Ambulance Service with a gentleman who has spent almost 20 years in the system, senior paramedic, Mr. Timothy McLean. Mr. McLean, thank you so much for joining us on your program.
Thank you so much for having me here.
You're most welcome. Now, I want to first start by looking at why you wanted to become a paramedic.
Oh boy. Why I wanted to become a paramedic. Let me put it this way. I've always been in the environment of caring for people. That has always been my life. Prior to being a paramedic, I was a police officer.
Really?
But there was a drawing for me more care for people. And I felt then that environment was not conducive for what I wanted to accomplish. So hence then I made the transition.
And people get a little confused between EMTs, emergency medical technicians, and paramedics. So what's the difference?
Well, okay, an EMT gives basic life support. So an EMT is trained to attend any scene which we are called of service, to give medical treatment for both accidents or persons that are injured, persons who are sick, and give basic life support in terms of CPR, managing the area. The difference is when it comes to a paramedic goes into a little bit more extensive care. We do more cardiac monitoring. We give medications. Because we are governed by medical protocol, which allows us then, by that protocol, to able to look at the signs and symptoms of a patient, what they present with, what problems they have, if they have severe bleeding, person have severe vomiting, the case may be, and as a result then by that protocol give medications to manage that person's problem before we transfer them to the hospital.
I want to look at that medical protocol some more. Go into some more detail about that.
Okay, so for instance, our medical protocol outlines for us signs and symptoms. Let's say for instance, a person that presents for a cardiac event. So the person has cardiac chest pain. It would give us an idea then that chest pain mid-central, radiated down to the left arm. The person may have vomiting, the person may have diaphoresis, person may have abdominal pain. We place that person on a cardiac monitor to look at the person's cardiac mapping to see if we can identify if there is something going on with the person's heart. But based on those signs and symptoms, we've already concluded that that person more likely is having a cardiac event. And then we can add to that the person's hypertensive, the person's a diabetic patient. Those things brings us into a more closer diagnosis that this is probably a cardiac event. Now, if that person has what we call those cardiac chest pain, we call ischemic chest pain, we can administer from there things like GTN. Is a spray which goes on the person's tongue, which again minimizes or withdraws the person's pain. It opens up the person's vessels to allow for more flow of blood to the person's cardiac muscles. We can give the person aspirin. And aspirin again allows then for if there's any clot that was there that was blocking the flow of blood, it prevents that clot from becoming much bigger. So then more blood can then pass to prevent any muscle death behind that clot. Right? So we look at those signs and symptoms, we can then mitigate from there. We can give the person these various medications to stabilize and manage that patient before they're transferred to hospital. What that does for that patient is to stabilize them to prevent them from getting any worse. So by the time they get to the hospital, then we can do more advanced management to prevent that person's heart from becoming further damaged.
So based on everything that you just explained, paramedics and EMTs undergo intense training, medical training.
Of course. Our training is presently done at the Barbados Community College. The EMT training at present is a 3-month course. And that 3-month course is a very intense program. We will love that program to be much more longer, to allow persons to able then to have more time to assimilate all the information that they're gaining. But at present, it is a 6 months program. And then during that program is very intense training in terms of both didactic training in classroom teaching, in anatomy, physiology, pharmacology. Persons do understand how to manage a person who's in a accident or involving trauma, and a person who's just generally ill. Likewise, the paramedic course would be a year, but we have now moved that program now, and starting from next year, that program will be 2.5 years. And the training is just as extensive and even more so because not only are they at community college doing the training both in the classroom and then understand the same things in terms of how to manage a person in more detail who's involved in trauma or person who's medically ill, but then they have to do training at the hospital where you're doing training both in accident emergency department, you're involved in labor ward and management of persons who are pregnant and in labor and or have difficulties in labor. And then you spend some time also in surgery when you learn how to manage a person who have area management issues. So the training is a very extensive training, and we want that as when they get on the road, that the general public can be very assured and confident that the person that are coming to them knows exactly what they're doing.
What are some of the biggest challenges that you and your colleagues face when you go to a scene?
One of the biggest challenges is that persons minimize what we do, minimize who we are. They think that we are, put it to a better way, we are just taxi men. So we just come to collect them, put them in the ambulance and go. So everyone wants to rush us, just get the person and go along. But that's not what we do, that's not our function. In fact, that minimizes our responsibility. And if we do that, we are liable by law. Our responsibility is to, again, manage it, look at the patient, assess the patient's condition, document that patient's problems on a run report, which is a legal document. That document goes one with the patient and the patient's medical files. And the next document is kept here. Those documents can be called to court. Let's say the patient was involved in an accident that ends up before court, or the patient was involved in a trauma incident that is a criminal case, or the person ended up suing someone for whatever reason, and now we are called to give evidence. That file can be pulled, And therefore, when we were there, the court will look at what did we see when we get there, what did we document when we get there, what was the person's condition or problem when we arrive, and what did we do in terms of managing that person's illness or injury. Because what we do or did not do can either one, advance that person's life to make sure that their quality of life is maintained, or may they get the hospital in a much better state. Or if we do not do what we're supposed to do, we can also hamper that person's life as well.
I always think about EMTs and paramedics and the trauma that you see.
Oh, yeah.
I cannot begin to imagine what you do see on a daily basis.
Well, EMTs and paramedics see it from the very rawest way. We are right there in the person's home. The person have been vomited. Person is severely bleeding. The person is completely has defecated himself. And we have to deal with all of that and then package that person and bring them down to the hospital. We are involved in accidents where persons are mangled in accidents. Yeah. And sometimes, I myself have experienced persons dying in my hands. At accident scene, we are trying to get the person to get the person out of the vehicle. But because of how mangled the person is into the vehicle itself, it takes time, and the person could pass during that process of time. We've had cases of the person who had multiple stab wounds, multiple gunshot wounds, and you're managing that person, and the person dies with you, or while it's being transported to hospital, or on arrival at hospital. And you have to be able to hone all of your skills and how to stop all that bleeding, take vital signs, document all that information all at the same time. And if the person goes into what we call cardiac arrest, you're managing that extensive bleeding. You're managing person, but the person is erratic or very restless. You're still trying to take vitals, and then if the person goes into arrest, do CPR while he's traveling at high speed.
That is a lot. And it's a lot for the person after they take off their uniform and go home as well. In terms of counseling, is counseling offered?
Well, counseling is offered. But I think most of the guys have become so, hardened by it, in that they've become so accustomed to doing it. Most of them may not go to counseling, but counseling is offered through the hospital. For kids, I can remember years ago we had a case, we had the Joes River accident.
Yes.
Right, a very massive accident, and many persons died in that accident. And a lot of persons had to have counseling then because of the graphic nature of that event. And not just us at the ambulance service, but persons outside the ambulance service that went to the event itself. But it can become quite overwhelming, especially if you see a young child who's involved in an accident or involved in some level of injury or very, very sick, and that person dies or succumbs to their injuries, either with you, either when you get to the house itself, or en route or at hospital. I can remember years ago I attended a case where a young child had an asthma attack, and a very serious asthma attack, to the point that a very young boy, he died. And just the emotion of it, it took a little time to take it all in and to breathe again, because the family was, severely distraught. And just the event, the moment of being there, seeing that, being in their presence was very emotionally overwhelming.
What do you want Barbadians to know about the service that the emergency ambulance service provides, both specifically the EMTs and the paramedics?
I would love Barbadians to really appreciate the level and quality of service offered by both EMTs and paramedics. To be in their presence when they are extremely ill, sick, or injured, or whatever complaint that they have, and to have to deal with managing that in a very open environment, and handling the emotion of it for our own selves, managing the extent of the circumstances, regardless of what story or what circumstance would cause their injury. Being able to manage all that information, manage the gravity of it, perform the skills that we have to perform to save their life, to maintain the quality of life that they have until they get to hospital. I really love Barbadians to really appreciate the level of service that we offer and what it takes to accomplish all of that. The level of training it requires for us to do to be able to give them the level of care that we do provide.
Well, let me, on behalf of myself and all Barbadians, say thank you to you and your colleagues for all that you are doing.
Thank you very much.
You're most welcome. That was Mr. Timothy McLean, a senior paramedic with the Barbados Emergency Ambulance Service. Before him, we spoke with the head of the service, Dr. David Beyer. I'm Lisa Lord. You're watching One on One. Do have yourself a wonderful evening.